Good afternoon, our dear students, and today we have the last lecture of the hematology course, and the topic will be hemophilia and thrombocytopenic purpura. So let's start from what is hemostasis exactly, which is a dynamic process in which the platelet and the blood vessel wall play key roles. Platelets become activated upon adhesion to Willebrand factor and collagen and exposed subendothelium after injury. Platelet activation is also mediated through shear forces imposed by blood flow itself, particularly in areas where the vessel wall is diseased, and is also affected by the inflammatory state of the endothelium. The activated platelet surface provides a major physiological site for coagulation factor activation, which result in further platelet activation and fibrin formation. Genetic and acquired influences on the platelet and vessel wall, as well as on the coagulation and fibrinolytic systems, determine whether normal hemostasis or bleeding or clotting symptoms will result. Platelets are released from megakaryocyte and they are part of our blood system and likely under the influence of the flow in the capillary sinuses, they will appear from megakaryocyte. The normal blood platelet count is around 150 to 450 nanoliter, and the major regulator of the platelet production is the hormone called thrombopoietin, which is synthesized in the liver. Synthesis is increased with inflammation and specifically by interleukin 6. Thrombopoietin binds to its receptor on platelets and megakaryocytes, by which is removed from the circulation. Thus, the reduction in platelet and megakaryocyte mass increases the level of troponin, which then stimulates platelet production. Platelets circulate with an average lifespan of 7 to 10 days, and approximately one-third of the platelets reside in the spleen, and this number increases in proportion to the splenic size. Platelets are physiologically very active but are anucleated cells and thus have limited capacity to synthesize the new proteins. Normal vascular endothelium contributes to preventing thrombosis by inhibiting platelet function. When vascular endothelium is injured, these inhibitory effects are overcome and platelets adhere to the exposed intimal surface primaries through the von Willebrand factor, a large multimeric protein present in both plasma and in the extracellular matrix of the subendothelial vessel wall. Platelet adhesion results in the generation of intracellular signs and signals that lead to activation of the platelet glycoprotein 2B and 3A receptor and resultant in platelet aggregation. Activated platelets undergo release of their granule content, which include nucleotides, adhesive proteins, growth factor, and procoagulants that serve to promote platelet aggregation and the blood clot formation and influence the environment of the forming clot. During platelet aggregation, additional platelets are recruited to the site of the injury, leading to the formation of an occlusive platelet thrombus. The platelet plug is stabilized by the fibrin mesh that develops simultaneously as the product of the coagulation cascade. The concept of stepwise process or cascade of the coagulation system was firstly described in 1964, while this traditional model describes two separate pathways, the intrinic and the extrinsic pathways that culminate in the common pathway. Current views support an interconnected relation between two previously named. The contact pathway, also called kallikrein-kinin system, is composed of three zymogens: factor 12, plasma kallikrein, and high molecular weight kininogen. In vivo, the activation of factor 12 at the start is still under discussion, so that current studies consider tissue factor and transmembrane glycoprotein expressed in perivascular tissue to be the main initiator in vivo or in our body blood clotting. I need to remind you probably that there are several factors of clotting, currently 31 present in the table on the left side or on this picture in the right side, which promotes, some abbreviation, I would say, which can help you to memorize them from 1 to the 13, the last one. Coagulation cascade is activated, as we already said, by two pathways, extrinsic and intrinsic, which culminates in the common pathway. The extrinsic pathway is thought to be the more important pathway as regards clot formation. It's primarily responsible for the formation of the large amounts of thrombin. Damage to blood vessel endothelium leads to a release of the tissue factor. Tissue factor has multiple effects, including the activation of the factor 7 of clotting. The tissue factor and the factor 7 complex activate the factor 10. Factor 10 itself, along with the inositol factor, activates thrombin. Thrombin has a very variety of the effects and by itself is sufficient to amplify and propagate the coagulation cascade. However, the most important functions of thrombin are activation of fibrin and activation of factor 13. Fibrin is primarily responsible for hemostatic plaque formation, while activated factor 13 initiates covalent bonding of fibrin. During this time, the intrinsic pathway is also activated. The intrinsic pathway provides cofactor support and involves mostly intravascular compounds. The prothrombin time and the international normalized ratio reflects the extrinsic pathway, while the partial thromboblastin time reflects the intrinsic pathway. Factors 2, 7, 9, and 10 require calcium, or factors 4, and phospholipids for activation. These vitamin K dependent coagulation factors are affected most by the liver disease and warfarin. Extrinsic pathway is affected and hence prothrombin time and international ratio is elevated. If normal prothrombin time is around 20 to 16 seconds. Prothrombin time and international normalized ratio are the same thing technically. Antithrombin 3 inhibits the factor 2A or thrombin and the factor 10. Tissue plasminogen activator like streptokinase converts plasminogen to plasmin, and plasmin degrades fibrin, and tissue plasminogen activator are used as thrombolytics or fibrinolytics in the therapy of coagulation problems. Factor 12 is only protein in the coagulation cascade whose deficiency does not cause any bleeding but rather result in prothrombic state. How the patient with actually any clotting problems should be investigated, or I would say that what kind of laboratory investigation will help you to make differential diagnosis and to make actual diagnosis of the patient. So let's start from the blood count and film, which can show the number and morphology of the platelets and any blood disorder as leukemia or lymphoma or anemia, doesn't really matter. The normal ratio for the platelet count, which is already named, 150 to 400 or 450, depending on your laboratory ranges. The next parameter is a bleeding time that measures platelet plaque formation in vivo. Normally between from 3 to 10 minutes, and prolonged bleeding time are found in patients with the platelet function defects. Third one is the bleeding time, which is the time taken for standardized skin puncture to stop bleeding. Measure platelet plaque formation in vivo usually represents, or assessment of platelet response to limited vascular injury, normally between from 3 to 10 minutes, and prolonged bleeding time are found in patients with platelet function defects. Coagulation tests include several ones, and one of the most frequently used is the prothrombin time, which is the time needed for the plasma to clot in the presence of tissue thromboplastin and calcium. Evaluate the ability of the blood to clot properly. Normal time is from 10 to 14 seconds, and prolonged prothrombin time results from deficiency of, it could be deficiency of factor 5, 7, 10, prothrombin, or fibrinogen deficiency. The other one is the thrombin time, which is measuring of the clotting time of plasma after adding thrombin. Normal clotting time is from 14 to 16 seconds, and prolongation of this parameter results from the deficiency of fibrinogen or dysfibrinogenemia. The partial thromboplastin time is the time that needed for the plasma to clot in the presence of the surface activator, cephalin, and calcium. Normal clotting time is around 40 seconds, and prolongation of this parameter could be due to deficiency of several clotting factors, also prothrombin and fibrinogen. Thrombocytopenia, we will talk in this lecture, results from one or more of these three major processes. It's decrease of the bone marrow production, sequestration usually in the enlarged spleen, or increased platelet destruction. Disorders of production may be inherited or acquired. In evaluating of the patient with thrombocytopenia, key step is to review the peripheral blood smear and to first rule out the pseudo-thrombocytopenia, particularly in the patient without an apparent cause of further thrombocytopenia. So impaired production could be seen in patients with bone marrow failure, megaloblastic anemia, aplastic anemia, myelofibrosis, multiple myeloma, HIV infection, more marrow infiltration in patient with cancer, in patient with deposition diseases, in patient, for example, with amyloidosis, leukemia, and leukemias, different type. Increased consumption usually seen in patients with immune thrombocytopenic purpura, drug-induced thrombocytopenic purpura, post-transfusion purpura, also in disseminated intravascular coagulation, and thrombocytopenic purpures. So what kind of evaluation requires the patient with thrombocytopenia? In patients with infection-induced thrombocytopenia, which can be cause of many viral and bacterial infections, and this type of thrombocytopenia are the most common non-iatrogenic cause of thrombocytopenia. This may or may be not associated with laboratory evidence of disseminated intravascular coagulation, which is the most commonly seen in patients with systemic infections due to gram-negative bacteria. Infection can affect both platelet production and platelet survival. In addition, immune mechanism can be at work, and in the infectious mononucleosis and early HIV infection. I'm sorry. Drug-induced thrombocytopenia caused by many drugs can be an predictable disease in the platelet count occurs after the treatment with many drugs due to bone marrow suppression. Classical drug-dependent antibodies are antibodies that react with specific platelet surface antigens and result in thrombocytopenia only when the drug is present. Drug-induced thrombocytopenia due to heparin differs that's seen from the other drugs in two major ways. The first one is that thrombocytopenia after the heparin treatment is not usually severe, and with a nadir counts rarely less than 20 nanoliter. Heparin-induced thrombocytopenia is not associated with bleeding and in fact markedly increases the risk of thrombosis. This type of thrombocytopenia results from the antibody formation to a complex of the platelet-specific protein platelet factor and heparin. The anti-heparin antibody can activate platelets through their specific receptor and also activate monocytes and endothelial cells. Usually, heparin-induced thrombocytopenia appears on the third or fourth day of the heparin treatment, so you should remember about it. And actually, coagulating parameters should be prescribed for a patient at first due to possible risk of bleeding. The second one is that due to possible heparin-induced thrombocytopenia due to appearance of specific antibodies to the heparin. The history and the physical examination results of the CBC and the review of the peripheral blood smear are all critical components in the initial evaluation of the thrombocytopenic patients. The overall health of the patient is and whether he or she receiving drug treatment with influence in differential diagnosis. Except in unusual inherited disorders, decreased platelet production usually results from the bone marrow disorders that also affect red blood cell and white blood cell production. Because myelodysplasia can present with isolated thrombocytopenia, the bone marrow should be examined in the patient presenting with isolated thrombocytopenia who are older than 60 years of age. While inherited thrombocytopenia is rare, any prior platelet count should be retrieved and the patient history regarding thrombocytopenia obtained. A careful history of drug indigestion should be obtained, including non-prescription and herbal remedies, because drugs are the most common cause of the thrombocytopenia in the usual practice. The physical examination can document an enlarged spleen, evidence of the chronic liver disease, and other underlying disorders. Mild to moderate splenomegaly may be difficult to appreciate in many individuals due to body habitus or obesity, but can easily assessed by abdominal ultrasound. A platelet count less than 10,000 in nanoliter is required to maintain vascular integrity in the microcirculation. When the count is markedly decreased, petechia first appear in the areas of increased venous pressure and the ankles and feet in an ambulatory patient. Petechia are pinpoint, non-blushing hemorrhages and are usually a sign of decreased platelet number and not platelet dysfunction. Wet purpura, blood blisters that form on the oral mucosa are thought to denote an increased risk of life-threatening hemorrhage in the thrombocytopenic patient. Excessive bruising is seen in disorder in both platelet number and the platelet function. Thrombocytopenic purpura can be divided in two major classes. Thrombotic thrombocytopenic purpura, which can be congenital as a result of mutation of the gene responsible for the synthesis Adams 13 specific factor, and idiopathic or autoimmune, where antibodies direct against this factor are created. You should remember that pregnancy is one of the known cases of this type of the thrombocytopenic purpura. And another type is immune thrombocytopenic purpura that can be usually acute and the chronic. Acute one is the most common form and seen mostly in the young children. Characteristics include symptoms that follow a viral illness, such as chickenpox or respiratory viruses, very sudden onset, symptoms that disappear in less than 6 months or even a few weeks, and treatment is often not needed and the disorder usually does not recur. And chronic thrombocytopenic purpura. It's the adult type of purpura more often than children ones and does not affect adolescents. Characteristics of the chronic purpura are the disorder can happen at any age and symptoms can last a minimum of 6 months, several years, or even lifetime. Women developed it 2-3 times more often than men, unfortunately, and it can recur often and require continual follow-up care for the blood specialist. Immune thrombocytopenic purpura was previously known as idiopathic thrombocytopenic purpura. The term idiopathic no longer applies because the etiology is known. Immune thrombocytopenic purpura caused by dysregulation of the immune system. The term purpura have been abandoned because it's misleading. Almost 1/3 of the patients with newly diagnosed purpura have no bleeding despite their low platelet counts. In adults, most causes of immune thrombocytopenic purpura are chronic, manifesting with the insidious onset and occur in the middle-aged woman. This clinical presentation suggests that the triggering events may be different. In chronic purpura, for known reasons, membrane glycoproteins on the surface of the platelets become immunogenic and stimulating the production of platelet autoantibodies. In acute immune purpura, the stimulus for autoantibody production is also unknown. The person with chronic purpura, approximately 75% of autoantibodies are direct against the platelet glycoprotein complexes. The annual incidence of this disorder is estimated to be 5 cases per 100,000 children and 2 cases for 100,000 of adolescents or adult people. Spontaneous occidental trauma-induced intracranial hemorrhage is the most frequent cause of the death and associated with this disorder. In the middle-aged adults, women are affected more frequently than men. The factors that initiate autoantibody production are unknown, but despite we already knew that the cause of the disorder is autoantibody production. Most patients have antibodies against several platelet surface glycoproteins at the time of the disease becomes clinically evident. Antibody-coated platelets bind to antigen-presenting cells, macrophages. Through the specific receptor and are internalized and degraded. Antigen-presenting cells not only degrade glycoprotein, thereby amplifying the initial immune response, but also may generate cryptic antitopes from the other platelet glycoproteins. They are colored with the blue. Activated antigen-presenting cells expresses these novel peptides on the surface along with the co-stimulatory helper. Here we are again. Here's there's glycoprotein specific one, and the relevant cytokines that facilitate the proliferation of the initiation CD4 positive T cell clones. First one is for those with additional specificities, T cell clone 1 and B cell immunoglobulin receptors that recognize additional platelet antigens are thereby also induced to proliferate and synthesize anti-glycoprotein antibodies. They are greenish here, in addition to amplifying the production of anti-glycoprotein antibodies by B cell clones. So appearance of the antibodies and glycoprotein binding leads to formation of T and B cell clone that can produce autoantibodies to glycoprotein and stimulates the coagulation. The spleen and the site of autoantibody production is also the site of phagocytosis of autoantibody platelets in the red bulb. The slow passage of platelets through the splenic sinusoid with a high focal concentration of autoantibodies and gamma receptors of splenic macrophages lend to uniqueness of the spleen at the site of the platelet destruction. Low affinity macrophage receptors bind immune complexes, immunoglobulin G, and are the key mediators of the platelet clearance. The mononuclear macrophage system of the spleen is responsible for removing platelets in patients with immune thrombocytopenic purpura, as demonstrated by the fact that splenectomy results in prompt restoration of the normal platelet counts in the most patients with this disorder. Platelets are sequestrated and destroyed by mononuclear macrophages, which are neither reticular nor endothelial in origin. Immune destruction of immunoglobulin-coated platelet is mediated by macrophages, immunoglobulin G, F factor, and complement receptors. The medical history of the patient with immune thrombocytopenic purpura should focus on the following. First one, the factors that suggest another disease for which thrombocytopenia is a complication, and the signs and symptoms that differentiate mild, moderate, and severe bleeding tendencies. Consideration for other systemic illnesses should include, in adults, thrombocytopenia, which may be a manifestation of systemic lupus erythematosus or acute or chronic leukemia, and also, for example, vasculitis. Thrombocytopenia may be a manifestation of myelodysplastic syndrome, particularly in patients older than 60 years. In young children, it can manifest as a primary immune deficiency syndrome. In persons infected with HIV, thrombocytopenia may occur during the acute retroviral syndrome, coincident with the fever, rash, and sore throat. For diagnosis of the drug-induced thrombocytopenia to be made with the confidence, all the following criteria must be met. We call them clinical criteria for making diagnosis. First one, the development of low platelet count should exhibit a strict temporal relationship with the initiation of the medication. The platelet count should recover when the offending medication is discontinued. The likelihood of the drug-induced thrombocytopenia should be greater than other plausible cause. Ideally, in vitro evidence of drug-dependent antibody formation should exist. Determine the extent and duration of the bleeding tendency to estimate the severity of the illness and the potential risk for the serious hemorrhage. Previously surgical history can often provide a useful clue regarding the acuteness of the thrombocytopenia. Query patient to elicit signs or symptoms of intracranial bleeding, such as headache, blurred vision, somnolence, or loss of the consciousness. Immune thrombocytopenic purpura is the primary illness occur in otherwise healthy person, and signs of the chronic disease, infection, wasting, or poor nutrition indicate that the patient has another illness. Vital signs, hypertension or bradycardia may be signs of increased intracranial pressure and the evidence of undiagnosed intracranial hemorrhage. On cardiovascular examination, distant low-amplitude heart sounds accompanied by the jugular venous distension may be evidence of hemopericardium. On abdominal examination in children and in acute purpura, the presence of the readable palpable spleen is not typical. In adult, otherwise, hepatosplenomegaly is also atypical for the immune thrombocytopenic purpura and may indicate chronic liver disease and the other diseases. In fact, splenomegaly excludes the diagnosis of immune thrombocytopenic purpura. Fundoscopic examination reveals whether the emergence of the optic disc is blurred. Examine the patient for the presence of retinal hemorrhages and other evidence of increased intracranial pressure as a cause of the purpura. The initial impression of the severity of this disorder is formed by the examining the skin and mucous membranes. Widespread petechia and ecchymosis oozing from the venipuncture site, gingival bleeding, and the hemorrhagic bulla indicated that the patient is at risk for the serious bleeding complication. Mild thrombocytopenia and relatively low risk for the serious bleeding complication may manifest as petechia over the ankles in the patient who are ambulatory or on the back in the patient who are bedridden, as we remember, in the areas of the biggest pressure. Laboratory testing for antibodies is usually not helpful due to low sensitivity and specificity of the current tests. Bone marrow examination reveals the cellularity of the aspirate and the morphology of erythroid and myeloid precursors, which is the normal. The number of megakaryocytes may be increased, although patients require a careful examination of megakaryocyte morphology to exclude the early myelodysplastic syndrome for all patients over the 60. The peripheral blood smear may show large platelets with otherwise normal morphology, and the morphology of the red blood cells and leukocytes is normal also. Depending on the bleeding history, iron deficiency anemia may be present. Clumps of the platelets of the peripheral smear prepared from ethylene diamine tetraacetic acid, anticoagulated blood are evidence of the pseudo-thrombocytopenia. Laboratory testing is performed to evaluate the secondary causes of disorder and should include testing for HIV infection, hepatitis C, and other infections as indicated. For example, it can be influenza virus or hepatitis even B viruses. Serologic testing for lupus erythematosus, serum protein electrophoresis, immunoglobulin level to potentially detect hypogammaglobulinemia, Selective testing for immunoglobulin A deficiency and monoclonal gammopathies and testing for Helicobacter pylori infection should be considered dependent on the clinical circumstance. And it's the point where the anamnesis taking can help you to find the right serological testing. If anemia is present, direct antiglobulin test or Coombs test should be performed to rule out combined autoimmune hemolytic anemia with immune thrombocytopenic purpura called the Evans syndrome. Computed tomography scanning and MRI scanning are relatively benign and useful non-invasive imaging studies that can be used to rule out other causes of thrombocytopenia. However, they are not part of the routine evaluation of the patient and serve as differential diagnosis methodics rather than the finding of diagnosis methodics. The goal of the medical care for immune thrombocytopenia is to increase the platelet count to a safer level and permitting the patient to live normal life while awaiting spontaneous or treatment-induced remission. Corticosteroids remain the drug of choice for the initial management of acute immunothrombocytopenic purpura, especially in the setting of the life-threatening thrombocytopenia, or when a response in the platelet count is needed in an urgent or emergent setting. Treatment with corticosteroids may not only reduce the rate of the platelet destruction, but may also rapidly obtain endothelial cell integrity to facilitate primary hemostasis and to reduce bleeding and bruising. In adults, treatment is recommended for the platelet count below 30 milliliter. If treatment is needed, short corticosteroid courses, less than 6 weeks, are preferred over the prolonged courses. The guidelines suggest either prednisolone or dexamethasone as the type of corticosteroid for initial therapy. In Eastern countries, the dexamethasone is widely used, but in Western Europe, it's rather prednisone are used. So depending on your country guidelines. Thrombopoietin receptor agonist and rituximab are the second-line option for the patient with immune thrombocytopenic purpura lasting over the 3 months, and in those who are corticosteroid dependent or have no response to corticosteroids. For adults who have had immune thrombocytopenic purpura for longer than 12 months, splenectomy is also a second-line option. Intravenous immunoglobulin can be a drug of second choice after corticosteroids for some patients, such as when a rapid increase in platelet count is important. So treatment of immune thrombocytopenic purpura initially consists from corticosteroids in present with or in absence of intravenous immunoglobulin or anti-D factor. If patient treatment is not successful, initial treatment wasn't successful, or after some period of time of partial recovery, the disease will come back. The combination or the monotherapy of the rituximab or anti-D drug or immunoglobulin intravenously or thrombopoietin receptor agonist can be used. If all this will not help, the splenectomy laparoscopic should be assessed as a treatment of the patient. In case of the worsening of present immunothrombocytopenic purpura, there are several additional agents as a chemotherapy, cytotoxic therapy, or autologous immune transplantation can be used for treatment of the patient. Thrombotic thrombocytopenic purpura is the rare blood disorder characterized by clotting in the small blood vessels, resulting in the low platelet count. In its full-blown form, the disease consists of the following pentate, so 5 major clinical symptoms: microadenopathic hemolytic anemia plus thrombocytopenic purpura plus neurological abnormalities plus fever and plus renal disease. In 1924, Elie Moshevitz, a doctor, described a girl who presented with an abrupt onset of petechiae and the pallor, followed by rapidly paralysis, coma, and death. Upon pathological examination, the small arterioles and capillaries of the patient were found to have thrombi consistent mostly of platelets. Doctor hypothesized that a powerful poison which had both agglutinative and hemolytic properties as the cause of the disease. Incidence of this type of the purpura associated with severe ADAM13 deficiency is over 9 times higher in the black people than in other races. The incidence rate of the thrombocytopenic purpura syndrome comparing women and men was more than 1. The main histopathological finding in this type of purpura is hyaline thrombi formed by the platelet aggregation. Those thrombi are responsible for capillary occlusion with the ischemia in different organs. These thrombi consist predominantly of the platelets with the little fibrin and red cells compared to the thrombi that occur secondary to intravascular coagulation. The von Willebrand factor plays a key role in the platelet aggregation. This factor produced exclusively in endothelial cells and platelets and is stored as a viable palate granule in the endothelial cells and as an alpha granule in platelets. After being secreted, factor attaches to the endothelial surface. The longer this factor is, the greater the effect of the platelet aggregation because it's more related to the platelet's 1b receptor. The role of ADAM13 factor is to split the von Willebrand factor into the smallest molecules. Regarding idiopathic thrombocytopenic purpura, findings show that it's an autoimmune process mediated by immunoglobulin G class antibodies. In the congenital form of the disorder, mutation in the gene encoding this protease have been described. ADAM13 activity levels of less than 10% are more clearly associated with the idiopathic or antibody-mediated thrombocytopenic purpura. Patients with thrombotic thrombocytopenic purpura typically report an acute or subacute onset of the following symptoms related to central nervous system dysfunction, anemia, or thrombocytopenia. Neurological manifestations include alternation in the mental status, seizures, hemiplegia, paresthesis, visual disturbances, and aphasia. Fatigue may accompany the anemia. Severe bleeding from thrombocytopenia is unusual, so petechiae are common. Clinical manifestation will also include the following: fever that occurs in approximately 50% of patients, and patient may notice like urine from hemoglobin urea. Complete blood count patient findings with this disorder are usually in follows. Total white blood count cell is normal or slightly elevated. Hemoglobin concentration is moderately depressed. Platelet count generally ranges from 20 to 50,000 in nanoliter. Peripheral blood smear will moderate to severe schistocytosis. I will remind you, that schistocytosis is a different shapes of the erythrocytes. Prothrombin time and activated partial thromboblasts in time results typically are normal in both thrombocytopenic purpura patients and in hemolytic uremic syndrome, which is another form of thrombocytopenic purpura. Also, some studies report patients with slight elevation of both tests. D-dimer and fibrinogenesis findings indicates there was normal or mildly elevation in patients with thrombocytopenic purpura. The D-dimer is indicative of fibrinolysis and thrombin activation. Fibrinogen typically is the high to high normal range. LDH called lactate dehydrogenase and bilirubin levels are indirect measures of the degree of hemolysis. As you remember, LDH is the enzyme that represents the damage of the multiple cell sequesters in our body. The higher LDL is, the high level of the blood was distracted in one or another way. So generally, moderate degree of hyperbilirubinemia is present with the indirect form predominating. The direct test determines the presence of autoantibodies on the red cells, and antibodies if present are more consistent with autoimmune hemolytic anemia. Because of association of thrombocytopenic purpura with HIV infection, serological evaluation for HIV infection should be obtained in all newly presenting patients. Imaging studies generally are not required in the evaluation of the patient, and in patient where the stroke is suspected, CT or MRI scan may be performed to rule out the fact or the hemorrhage. Stroke can be ischemic. In this case, we called it in fact or hemorrhagic. Yep. Biopsy is not required for the diagnosis of the patient, and when biopsy have been performed, they generally have revealed thrombi that are relatively platelet-rich and fibrin poor in the microcirculation. Because thrombocytopenic purpura is a medical emergency, long turnout times for ADAMS13 activities say result preclude the use of this test in the decision when or whether to start plasma exchanges as the treatment. To make accurate diagnosis, the clinician must recognize the similarity between thrombocytopenic purpura and hemolytic uremic syndrome. In general, the syndrome is diagnosed in the children and thrombocytopenic purpura diagnosed in adults. 90% of cases of the hemolytic uremic syndrome is children's cases. Clinical differentiation of these two syndromes can be problematic and often based on the presence of central nervous system involvement in the thrombocytopenic purpura and more severe renal involvement in case of the hemolytic uremic syndrome. In this hemolytic uremic syndrome, the antecedent history of diarrheal illness is more often present. In fact, some investigations suggest the clinical classification of HAS based on the presence of or absence of diarrhea. HAS and to some extent of the thrombocytopenic purpura commonly occur following a diarrheal illness with enterohemorrhagic Escherichia coli and Shigella dysentery serotype 1. These bacteria, besides causing bloody diarrhea, are able to secrete an exotoxin called the Shiga toxin or Shiga-like toxin. If you compare immunothrombocytopenic purpura, thrombocytopenic purpura, and disseminated intravesicular coagulation syndrome, you will observe that the causes, I will remind you, immune thrombocytopenic purpura is antiplatelet antibodies, for thrombocytopenic purpura it's endothelial defect, and for disseminated coagulation is thrombin excess. Clinical condition: patient with immune purpura feels not sick, but in thrombocytopenic purpura disseminated feels sick. In RBC, we will see schistocytosis in patients with thrombocytopenic and disseminated coagulation, and no important changes in the patient with immune purpura. Proton time or international ratio, a slightly increase in patient with thrombocytopenic purpura can be normal in patient with immune and increased in patient with disseminated coagulation. Prothrombin time will be increased in disseminated coagulation, slightly increased to normal in thrombocytopenic purpura and normal in immune purpura. Fibrin degradation, the same story, increased in disseminated coagulation, slightly increased in thrombocytopenic purpura, and absolutely normal in immune purpura. The D-dimer as representative of fibrin synthesis and degradation will be normal in immune purpura, increased in disseminated coagulation, and slightly increased in thrombocytopenic purpura. Treatment of this type of disorder in the presence of microangiopathic hemolytic anemia and thrombocytopenia in the absence of other obvious causes is justification to begin plasma exchange, preferably within 4 to 8 hours. Plasma exchange with fresh frozen plasma, and the therapy of choice for the therapy of choice for the thrombotic thrombocytopenic purpura. Replacement with normal saline and albumin is not adequate. When an immediate plasma exchange is not available, simple plasma infusion can be performed until the patient can be transferred to a facility that performs plasma exchange. Usually, at least 5 plasma exchanges are performed in the first 10 days. In patients whose thrombocytopenic purpura is refractory to plasma exchange, using cryoplasma or cryosupernatant has sometimes led to a response. In January 2019, the FDA, which is the most powerful pharmaceutical agency which can approve or disapprove any treatment in this world, the most serious organization can be trusted. So this organization approved caplacizumab for adults with acquired thrombocytopenic purpura in combination with plasma exchange and immunosuppressive therapy. It's an antibody fragment that targets A1 domain of the von Willebrand factor and inhibits the interaction between von Willebrand and platelets, thereby reducing both Willebrand-mediated platelet adhesion and platelet consumption. Corticosteroids are commonly given to patients with this disorder. Increasing evidence supported use of the anti-CD20 monoclonal antibody rituximab in causes of the purpura refractory to plasma exchange with resolution of acute disease and prolonged remission. The use of aspirin and dipyridamole also part of the standard therapy in the past, but has fallen out of favor. Vincristine and vinalkaloid, generally used as chemotherapy, has also shown to be useful in refractory cases. Platelet transfusion should be avoided unless life-threatening bleeding is present. In heparin-induced thrombocytopenia, which can occur after exposure of low molecular weight heparin, as well as unfractionated heparin, and is more common than the latter. This type of thrombocytopenia usually presents from 3 to 4 days of the treatment, but can be present also till the 14 days of the treatment with heparin. It occurs before 5 days in those who were exposed to heparin in prior few weeks or months and have circulating anti-heparin antibodies also. Rarely, thrombocytopenia and thrombosis begin several days after all the heparin have been stopped. The 4T have been recommended as criteria to be used in diagnostic algorithm for this disorder. So, to make diagnosis, heparin-induced thrombocytopenia should be present. Thrombocytopenia itself, timing of platelet count drop, thrombosis, and other sequelae such as localized skin reaction and other causes of thrombocytopenia not evident. Heparin-induced thrombocytopenia antibodies can be detected using 2 types of assays. The most widely available is enzyme-linked immunoassay called ELISA, with polyanon complex as the antigen, because many patients develop antibodies but do not develop clinically this disorder. The test has a low specificity for the diagnosis of the heparin-induced thrombocytopenia. In patients diagnosed with this disorder, imaging studies to evaluate the patient for thrombosis. Usually it's low extremity duplex Doppler imaging, and which is recommended. Early recognition is the key in treatment of this disorder, with a prompt discontinuation of the heparin and use of alternative anticoagulants, and bleeding risk does not overrate the thrombotic risk. Diet thrombin inhibitor argatroban is effective in the patient with heparin-induced thrombocytopenia. Biliverdin and the antithrombin binding pentasaccharide fondaparinux are also effective but not approved. So on this slide, it's represented the different type of the rash that can be present in patient, and I will try to help you to memorize some differences. So if we talk about petechias, which is the usual signs of the purpura, so you should notice that it's usually very small and red rash. Palpable, this rash can be in patient with vasculitis, but for patient with the purpura, it's rather non-palpable. In patient with meningococcemia, in which the cause of the rash is technically at first it's a thrombosis, thrombosis of the small vessels with further damage of the vesicular wall, appearance of the hemorrhage, and the other one, like in vasculitis, it's formation of immune complexes which penetrate the vessel wall. So in case of the meningococcemia, if there is no secondary vasculitis, this rash will not be palpable. If there is vasculitis or secondary vasculitis, different reasons, particular rash will be palpable. Patient with purpura, non-palpable, small, red, usually on the lower extremities or in the area with the biggest pressure. So if patient is bedridden, it could be on the back of the patient. This patient is sitting due to some reasons. It can be on the buttocks area or the posterior area of the hips. In other patients, it's usually legs or upper extremities, and if it's children. So purpuritic rash or petechia more than 0.4 centimeters, so it's bigger than small rash, petechial type of rash. They are maybe palpable, especially if they're caused by meningococcemia or different type of infectious purpuras. They are bigger. They can have necrosis in the center. They are not small and they are usually palpable. Vesicular bullous rash, according to its name, usually the cause of this rash is or herpes virus, or for example, different children, chickenpox and etc. disorders. So differs from the petechiae presented in patient with the purpuras because it's vesicular. It usually consists with some serous or non-serous, depending on the disorder contained. Usually they painful comparing with the petechial rash, as pruritic rash can be painful, especially in patients with infectious causes. So maculopapular rash, it's a problem of the usually infectious disorders, or patient with can be seen in patient with psoriasis or eczema or many different drug reaction, means allergic reaction to drugs. And there is not bloody rash, I would say, yeah, so it's rather pink than, because there's no blood leak. It's palpable. It can be present on the different part of the body of the patient, not connected with the areas of the biggest pressure comparing with the petechial valve. So if petechia is non-palpable, non-3D, flat, just technically small hemorrhage, macules, it's palpable, non-hemorrhagic rash that can addict to one in another and form, for example, big red areas over the skin surface of the patient. So causes of acquired platelet dysfunction include, except drug-induced, which is the most common one, is salicylate and SAIDs, dipyridamole, for example, and some of antibacterial drugs. Also, the cause is the alcohol due to the release of some toxic cases. Uremia is disease-related cause due to increase of the nitric oxide and decrease of release of the granules. Myeloproliferative disorder or myelodysplastic syndrome can cause acquired platelet dysfunction due to abnormal receptor functioning and signal transduction or the granular release. Cardiac bypass through the platelet activation in the bypass circuit can lead to acquired platelet dysfunction, and in this case, platelet transfusion should be prescribed for a patient to stabilize patient. So the last one, disorder of thrombocytes. So we will talk, and actually, rather hemostasis, not thrombocytes. So hemostasis. We will talk in this lecture. It's hemophilia, which is the X-linked recessive hemorrhagic disease due to mutation in the F factor 8 gene. And in this case, it's called hemophilia A, or classic hemophilia due to deficiency of factor 8 clotting factor, or clotting factor 9 gene deficiency, and in this case, it's called hemophilia B. Also exists hemophilia C, also known as plasma thromboplastin antecedent deficiency or Rosenthal syndrome. It is a mild form of hemophilia affecting both cases and due to factor 11 deficiency and not X-linked. The deficiency affects 1 in 10,000 of males worldwide and all ethnic groups, and the hemophilia A represents 80% of all cases. Male subjects are clinically affected. Women who carry a single mutated gene are generally asymptomatic. Family history of the disease is absent in 30% of cases, and in these cases, 80% of the mothers are carriers of the de novo mutated allele. The frequency of A hemophilia type is 1 per 5,000 live male births, whereas hemophilia B occurs in 1 in 25,000 live male births. Inheritance in the X-linked recessive, leading to affected males and carriers females. There is no race predilection. Testing is indicated for male infants with a hemophilic pedigree who are asymptomatic or who experience excessive bleeding, or for an otherwise asymptomatic adolescent or adult who experience unexpected excessive bleeding with trauma or invasive procedure. Hemophilia C is also primarily inherited, but it does not follow an X-linked pattern because the mutation that causes it affects the gene found on the chromosome 4, affects both genders equally. There is another type of hemophilia called parahemophilia or Oran disease. It's a congenitally deficiency factor 5 that is associated with hemorrhagic diathesis and abnormally slow clotting time. Fewer than 200 cases of congenital factor 5 deficiency have been reported worldwide since 1943. The severity of bleeding symptoms is only partially related to the degree of factor 5 deficiency in the plasma. The most common physical findings of this deficiency are ecchymosis, bleeding from mucosal surfaces, and pallor secondary to the blood loss. Fresh plasma or fresh frozen plasma infusion are used to correct the deficiency temporarily and should be given daily during a bleeding episode. Hemophilia resulted as deficiency factor through the extrinsic pathway is normal in this case, and bleed manifestation due to inadequate fibrogenesis, inappropriate fibrinolysis. Very high level of thrombin are required to activate thrombin-activate fibrinolysin inhibitors that augments a fibrin deposition by inhibiting of fibrinolysis. So in case of the hemophilia A, clotting factor 8 is a cofactor. In case of the hemophilia B, clotting factor actually 9 is enzyme. The history should be determined for all patients with hemophilia, the site of or sites of bleeding, the severity, the duration of the hemorrhage, and the age at onset. So not concentrated on the current hemorrhage, ask the patient about previous one too, and actually their course. You should ask patient, was the bleeding spontaneous or did it occur after trauma? Was there previous personal family history of similar problems? If a child or adolescent has had surgery that affects the mucosal surface, such as tonsillectomy or major dental extraction, the absence of bleeding usually rule out the hereditary bleeding disorder. For individuals with documented hemophilia, uncertain the type of deficiency, degree of factor deficiency, known presence of inhibitors, and HIV hepatitis status should be observed. For patients with mild to moderate disease, you should determine responsiveness to desmopressin acetate as a treatment of the possible complication and bleeding. The hemophilia A and B are indistinguishable clinically usually, and patients with hemophilia are present with early bruising, inadequate clotting of traumatic or even mild injury, or in the case of severe hemophilia, spontaneous hemorrhages. Signs of the hemorrhage include the following. It can be general signs usually attributed to anemia secondary to bleeding, and they are weakness, orthostasis, tachycardia, tachypnea. Musculoskeletal signs consist from tingling, cracking, warmth of the affected part, pain, stiffness, and the refusal to use joint because it's painful for children, or patient will tell you that there's a restriction of the joint use due to pain and due to problem with the joint's shape, size, etc. Central nervous system symptoms include headaches, stiff neck, vomiting, lethargy, irritability, and spinal cord syndromes. Gastrointestinal symptoms of the bleeding include hematometesis, melena, frank red blood per rectum, and abdominal pain. Hematuria, renal colic, and the post-circumcision bleeding can represent the genitourinary symptoms of the hemophilia. Epistaxis, oral mucosal hemorrhage, hematopoiesis, dyspnea, compartment syndrome symptoms, and contusion syndromes can represent other hemorrhageous symptoms. The systemic signs of hemorrhage include the following: tachycardia, tachypnea, hypotension, orthostasis. The organ system-specific signs and symptoms of the hemorrhage include the following: tenderness, pain with the movement of the joint and muscles, decreased range of motion, effusion, and warmth. Abdominal neurological exam findings, altered mental status, or meningisms. Gastrointestinal observation can be painless, hepatic splenic tenderness, and peritoneal sign can observe. Bladder spasm, distension, or pain, and costovertebral angle pain from genitourinary system. Hematoma leading to location-specific signs as airway obstruction or compartment syndrome, or problem with the joint using. So tachypnea and tachycardia, can appear as compensatory mechanism on the blood loss and decreased oxygen metabolism due to the loss of the blood and red blood cells. Hypertension represents a reaction to the volume loss for the blood, so less blood volume in the blood system and less ability to maintain the pressure. Clinically, hemophilia can be divided into three forms: mild, moderate, and severe, depending on what kind of injury can cause hemorrhage, frequency of bleeding, activity of clotting factors, and pattern of bleeding. So from joint soft tissue bleeding to bleeding after small, absolutely non-severe damages. Hemoglobin hematocrit expected to be normal or lower values in the patient with hemophilia. Platelet count expected to be normal if a patient has only hemophilia. In coagulation studies, the bleeding time and prothrombin time are normal. The activated partial thromboplastin time is prolonged. However, a normal activated partial thromboplastin time does not exclude mild or even moderate hemophilia because of the relative insensitivity of the test. This test is significantly prolonged in severe hemophilias only. For patients with hemophilia A, laboratory confirmation of factor VIII inhibitor is clinically important when a bleeding episode is not controlled despite infusion of adequate amounts of the factor concentrate. For this say, activated partial thromboplastin time measurement is repeated after incubating the patient plasma with normal plasma at 37 degrees Celsius for 1 or 2 hours. If prolonged parameter of thromboplastin activated time is not corrected, the inhibitor concentration is titrated using the Bethesda method. For patients with hemophilia B factor 9 assay and early diagnosis of factor 9 deficiency should be carried. Usually von Willebrand factor levels are also measured, and the combination of low Willebrand factor and low level of the factor 8 may indicate the von Willebrand factor deficiency as the primary diagnosis. For hemophilia C, specific assay for factor 9 activity is necessary to confirm the diagnosis. Assays of other closing factors and platelets function may be needed to exclude the combined hereditary deficiency of factor 11 or other factors. Radiography for joint assessment as of limited value in acute hemarthrosis. Evidences of chronic degenerative joint disease may be visible on the radiographs in the patients who have been treated or inadequately treated or in those with recurrent joint hemorrhages. In this patient, radiographs may show synovial hypertrophy, hemosiderin deposition, fibrosis, and damage to cartilage procuratus with the subchondral bone cyst formation. No imaging studies are necessary in diagnosing of factor 11 deficiency. However, imaging studies may be obtained to evaluate the extent of the bleeding in the management of the bleeding at any site. Early and aggressive imaging is indicated for patients with acute bleeds, even with low suspicion for hemorrhage after coagulation therapy is initiated. Imaging choices are guided by clinical suspicion and anatomic location of involvement. Head CT scans without contrast are used to assess for spontaneous and or traumatic intracranial hemorrhages. Perform magnetic resonance imaging on the head and spinal column for further assessment of spontaneous or traumatic hemorrhages. And MRI is also useful in evaluation of the cartilage, synovium, and joint space. On the CT head scans present on the slide, you can see the course of the intracranial hemorrhage. So at the presentation, it demonstrates a parietal subcortical hematoma that was evacuated and replaced by fibrous tissue at the end. On this slide, you can see the MRI of the knee joint of the 27-year-old hemophilic patient. In this view, an intra-articular blood can be noted in the lateral side of the joint. Here it is. While a medial side, a severe degree of synovitis can be seen. In the lateral view of MRI, the aforementioned hemarthrosis can also be noted. Hemarthrosis, I reminded, the presence of the blood inside of the joint capsule. Ultrasonography is useful in the evaluation of the joints affected by acute or chronic effusion. This technique is not helpful for evaluating the bone or cartilage. Special studies such as angiography or a nucleotide bleeding scan may be clinically indicated. Acute hemarthrosis are painful. Clinical signs are local swelling and erythema. To avoid pain, the patient may adopt a fixed position, which leads eventually to muscle contractures. Variant children unable to communicate verbally show irritability and lack of movement of the affected joint. Chronic hemarthrosis are debilitating with the synovial thickening and synovitis in response to the intra-articular blood. After joint has been damaged, recurrent bleeding episodes result in the clinically recognized target joint, which then established a vicious cycle of bleeding, resulting in progressive joint deformity that in crucial cases requires surgery and the only therapeutic option. Hematomas into the muscle of the distal parts of the limbs may lead to external compression of the arteries, veins, or nerves that can evolve to a compartment syndrome. The treatment of hemophilia A may involve prophylaxis, management of bleeding episodes, treatment of factor VIII inhibitors, and treatment and rehabilitation of hemophilia synovitis. Use of the factor replacement products and other medication, including pain medication, is typically required. The treatment of hemophilia B may involve management of hemostasis, management of bleeding episodes, the use of the factor replacement products and medication, treatment of patients with factor inhibitors, and treatment and rehabilitation of patients with hemophilia synovitis. The unpredictable nature of bleeding is a concern of hemophilia C, especially in patients with partial deficiency. Bleeding episodes can be predicted on the basis of factor XI levels alone. Thrombotic events are a risk in some patients who receive factor XI concentrates, particularly those with pre-existing risk factors such as older age, non-peripheral central vascular disease, or morbid obesity. Ambulatory replacement therapy for bleeding episodes is essential for preventing chronic arthropathy and deformities. Home treatment and diffusion by the family or patient is possible in most cases. Prompt and appropriate treatment of the hemorrhage is important to prevent long-term complications and disability. Many recombinant factor VIII concentrates are currently available. The advantages of such products is the elimination of viral contamination. Those calculations are directed toward the achieving of factor VIII activity level around 30 to 40%. For most mild hemorrhages, at least 50% for severe bleedings, or prophylaxis with a major dental surgery or major surgery, and up to 100% in the life-threatening hemorrhage. Hospitalization is reserved for severe or life-threatening bleedings, such as large soft tissue bleedings, retroperitoneal hemorrhage, or other internal bleedings, and the hemorrhage related to the head injuries, surgery, or dental work. Treatment of patients with hemophilia ideally should be provided through a comprehensive hemophilia care center, not dependent on the hemophilia serotype. These centers follow a multidisciplinary approach with specialists in hematology, orthopedics, dentistry, and surgery, nurses, physiotherapists, social workers, and related allied health professionals. Patients treated at comprehensive care clinics have been shown to have better access to care, less morbidity, or better overall outcome. Ambulatory replacement therapy for bleeding episodes is essential for preventing chronic arthropathy and deformities in treatment of hemophilia B. Factor IX concentrate are available to treat hemophilia of this type. Frozen plasma is no longer used in hemophilia because of the lack of the safe viral elimination and concerns regarding the volume overload. Cryoprecipitate contains no factor IX and is also not appropriate for factor IX therapy. Those calculations are directed toward the achievement of factor IX activity level for 30% for the most mild hemorrhages, up to 100% in the life-threatening hemorrhage. Hospitalization is reserved for life-threatening and severe bleedings, as in the patient with hemophilia A type. Non-transfusional therapy includes desmopressin antifibrinolytic drugs. So desmopressin is a vasopressin analog. Is considered the treatment of choice for mild and moderate hemophilia A. It's not effective in the treatment of severe hemophilia. It stimulates a transition increase in plasma factor VIII levels and may result in sufficient hemostasis to stop a bleeding episode or to prepare a patient for dental and minor surgical procedures. A test dose should be performed before prophylactic use. It can be intravenously administered dose 0.1 microgram by kilogram of the body weight in the inpatient setting. Or it can be prescribed as intranasal spray, which is available for outpatient use. Antifibrinolytic drugs is used for bleeding in the gums, gastrointestinal tract during oral surgery And these drugs are aminocapronic acid or tranexamic acid to control the local hemostasis. The duration of the treatment, depending on the clinical indication, is 1 week or longer. This drugs is given in dosage at 25 milligrams by kilogram 3 to 4 times a day. Aminocapronic acid requires a loading dose of 200 milligrams by kilo, followed by 100 milligrams by kilo per dose every 6 hours. Not indicated to control hematuria because of the risk of formation and occlusive clot in the lumen of genitourinary tract strictures. Another type of treatment for patients with hemophilia, it's inhibitors. So they are antibodies that neutralize factor VIII and can render replacement therapy ineffective. They are found more commonly in patients with moderate to severe hemophilia who have received significant amounts of replacement therapy. And the inhibitors develop in relatively young children, usually within their first 50 exposures of the factor VIII replacement therapy. Rarely, inhibitors can develop in individuals without genetic hemophilia. These occasionally are responsive to immunosuppressive therapy, and factor IX inhibitors are less common than factor VIII inhibitors. They occur found in around up to 3% of patients with severe hemophilia B. These inhibitors typically appear after the first infusion of factor IX concentrate. Inhibitors, it's technically it's antibodies to factor clotting factors, either 8 or 9. Emicizumab is the first in class bispecific monoclonal antibody that performs the function of activated factor VIII, bringing activated 9 and 10 to restore the coagulation cascade, but is unaffected by factor VIII inhibitors. Inhibiting antibodies, I think it will be correct. Recombinant activated factor VII has become the first choice of bypassing agent. Desensitization in non-emergency situation may also be feasible. Recombinant human coagulation factor VIIa is indicated for the treatment of the patient with bleeding episodes and for prevention of bleeding, surgical interventions, or invasive procedure in patients with inhibitors to factor IX. Desensitization in non-emergency situation may also be feasible. This therapy includes large doses of factor IX along with steroids or intravenous immunoglobulin and cyclophosphamide. Concizumab is subsequently administered monoclonal immunoglobulin G4 antibody that promotes thrombin generation by binding to the tissue factor pathway inhibitor, which is the primary inhibitor of the initiation of coagulation cascade. The prophylactic treatment has several goals, and the main one is to prevent bleeding symptom and organ damage, especially in joints. Hemophilia arthropathy that result in direct or target joint bleeding can be prevented by this method. Usually, hemophilia carriers with the factor levels less than 30% of normal have not been considered to be at risk for the bleeding. However, the wide range of values have been reported due to a random inactivation of the X chromosome, and it's important to measure the level factor of carriers to recognize those at risk of bleeding and to optimize pre-operative and post-operative management if needed. During pregnancy, both 8 and 9 factor levels increase gradually until the delivery. Factor VIII level increase approximately 2 or 3-fold comparing to non-pregnant women, whereas 9 factor increase in less pronounced categories. After delivery, there is a rapid fall in the pregnancy-induced rise of maternal clotting factor levels. This represents an imminent risk of bleeding that can be prevented by infusion of factor concentrate to levels up to 30% for the 3 days in the setting of vaginal delivery and up to 5 days for cesarean section. In mild cases, uses of this factor or antifibrinolytic drugs is recommended. Early hemophilia patients have more severe arthropathy and chronic pain due to suboptimal treatments and high rates of HIV and hepatitis C infection. Excessive replacement therapy should be avoided, and it's prudent to slowly infuse factor concentrates. Continuous infusion of clotting factors preferable to bolus dosing in patients with cardiovascular risk factors undergoing invasive procedures. So thank you very much for your attention during this hematology course of internal medicine lectures. If you do have any question, please send me them via email. And we will see you during the pulmonology course. So have a nice day. See you. Bye-bye.